Hi, I'm Danica Koopmans.
And I'm Sharon Hughes-Geeky. We're your hosts of Docs of Vernon. This is an interview and podcast series designed to help you navigate the healthcare system and get to know the physicians that provide your care.
Topics include what the heck is a hospitalist, treating addictions, and alternatives to going to the ER, plus so many more.
This is your link to healthcare in your community.
Interview Dr. Taylor Jespersen, and I'm super excited to have you because I see you obviously as my colleague but as a friend as well, and we have kids similar age, so that's really fun to go on that journey together. Dr. Jespersen was trained through UBC, and she did her training in Kelowna for part of it or all of it.
My residency, first year Kelowna, second year Smithers and Revelstoke.
Cool, so you have a rural edge to you. She also followed her passion all the way to Ireland, where she studied at the Royal College of Surgeons. And then after she completed her rural family medicine residency, you ended up staying here in Vernon, which is actually home.
Mm-hmm.
And now you are married to your high school sweetheart, and you have one beautiful boy and another on the way. So welcome, and thank you so much for being here.
Thanks for having me.
So one of the things we kind of talked about would be interesting topics to share. I think you guys will find these great as well, is the topic of over-testing. I think one of the questions that came up for me right away when you had mentioned that is just over-testing could mean anything from lab work to coming into emerge for various things to investigations like, do we need a CT? Do we need an MRI? And so I want you to just elaborate on that.
Yeah, it's something that I see a lot of in primary care. We're like the first point of contact for patients in terms of access to the medical system. And so if somebody has, new symptoms, they come to me, or maybe they just have questions about, hey, I haven't had blood work in a little while, or I haven't had imaging in a little while. And is that something that I need? So if we're talking about testing in a setting of somebody who doesn't have any symptoms, that's probably something that I get really commonly in my office, particularly young people who say, hey, I haven't seen a doctor in a few years, should I have a physical? And that's something we used to do a lot more in primary care. We used to do annual physicals on people, but we started to move away from that because there isn't really good evidence to support that it makes a meaningful difference for people. And what we do now is more targeted, individualized assessments, and that might happen on an annual basis. For some people, maybe that's every 5 years if you're younger. And we take into account, or I'll take into account what your current symptoms might be. Maybe that's nothing. What your lifestyle is. So do you smoke or drink a lot of alcohol, or maybe have a high stress job and that can impact your health? What's your family history, and has that maybe changed? And so I use all of those things to kind of guide, what is the most appropriate investigations for you. And for a lot of people, it's nothing.
Wow.
And so we don't have to do anything. And so sometimes that's a little bit unsettling for patients, but I actually think we're in an age where we have a lot of access to technology, to tests, to better imaging, and that doesn't come without harms because we're finding things that we don't know what to do with.
Yeah, that's a great point. Finding things that we don't always know what to do with. It's like incidental.
And like the other term we'll use is it clinically significant or clinically relevant? And what that means is this abnormality we found on your blood work or something on your imaging, is it going to lead to symptoms in the future? Is it something that could affect your quality of life? Is it something that could transform into something like a cancer or maybe even end your life? Those are things that are clinically significant. We care about those, but we find a lot of things that mean nothing, but we don't know what to do about them.
Yeah. And I think I'll even add to that, one of the things that I notice about this day and age is that it's actually sometimes more difficult to make the decision not to investigate something.
Yeah.
Right? It's like we could do all of this and it'd be really easy because then I just have an answer, but is that really clinically appropriate?
Yeah.
Is that using my critical thinking and knowledge?
Absolutely. And I think we, us as healthcare providers, but also the general public too, I think we, because of our access to technology, have really sort of undervalued and underestimated the power of a history and a physical. I can gain a lot of information about what might be going on just from asking you certain questions about, how would you describe that knee pain? Or is it pain, or is it more instability? Is it upstairs or going downstairs? I can get a ton of information on what's going on in your knee just by the way that you describe it. And then I can use my physical exam to kind of confirm that. A lot of the time I have a pretty good idea as to what's going on from those two pieces alone. And I don't need imaging to tell me that. I can give you an idea of, hey, I think this is what's going on. This is what the treatment is. Let's get you into physio, or let's get you some pain medications, or let's just give you a little time. That's obviously not every single case, but I think, there's an expectation that we need to have imaging, we need to have blood work, but there's actually a lot of training, and yours would have been the same. Huge amount of our training is just in the history and the physical. And those are really powerful tools.
Oh, you're a great clinician, aren't you?
Very passionate about it, because these things contribute to stress and worry in patients.
Yes.
There's lots of times I've done, imaging for, say, an abdominal ultrasound because I'm worried about something with the pancreas. But, because it's an abdominal ultrasound, it's generalized, they get everything, and they see a cyst on the liver. Well, that wasn't what we were looking for. The cyst doesn't mean anything, but now this patient has to worry about that. And they're wondering, is this going to turn into cancer? Is this something that's going to, cause me some harm in the future? Sometimes it might even have insurance implications, So those are harms that we have to think about years down the road. It causes unnecessary stress on physicians because now we have to track it. So do we need to do an ultrasound every year now? I have to have some sort of recall in place. And this is one of 1,200 patients in my practice that I have some sort of recall on that's popping up all the time. And then it's a huge burden on our healthcare system too, that's already overworked.
So that's really interesting. And I think one of the other things that I've noticed from also working rural, and you've seen this, is in rural medicine, we don't have access to a CT scanner often, or MRI, or, best thing we have is maybe bedside ultrasound. Yeah. And so often people have to live knowing that there's a risk involved with living rural. You might not have access to these things. But if you have a thorough clinician who does a good history and a good physical, you can gain a lot from that, right?
That's where I really credit the training that I received. I was trained as a rural physician, and then ended up landing and working where I grew up, which is much more urban. And so, I was trained to heavily rely on my clinical exam skills because we didn't have access, maybe at all, or just in a timely fashion to some of those services. And so you really just have to sit with that little bit of discomfort and unknowing, and that's actually okay too. But you come to a place like Vernon where we, generally speaking, compared to other places, have wonderful access to imaging and tests and specialists and things like that. And so sometimes when that access is easy, it can then just be easy to say, well, let's just do it just because, but it's not really good medicine.
Yeah, that's a great point. So something that you had mentioned a little bit earlier was in regard to physical exams. And the lack of need, really. And so I just wanted you to go into that a little bit more, because I think even in the back of my mind, it's almost like a myth that we need to have these.
Yeah. And I think, a physical exam, on an annual basis, just because, is not indicated anymore for most people. But what is indicated is, I call it in my clinic, a periodic health review or periodic health risk assessment. So it's in my practice, the way I set it up is it's an alert on everybody's chart that pops up every year. And I take the opportunity to quickly review, have I seen them recently? Are they now tipping into an age range where we should start screening and I haven't yet seen them? Or maybe, hey, they're due for their mammogram, or they haven't had their, like a 25-year-old, hasn't had their first PAP yet, or cervical cancer screening yet. And then I might recall that patient into the office and we'll just have a conversation. I'll say, hey, you told me last time you weren't smoking. Is that still the case? Or you were smoking. Have you stopped smoking? Last time we talked about how much alcohol you were drinking. Is that still the same? Any changes to your family history? And then once again, history, I get all that information. Then I might ask them, are you having any new symptoms? And then from there, I'll do appropriate parts of the physical exam And then we'll have a conversation of, do you need blood work? Are you due for screening? Stuff like that. And then I'll usually say to the patient, hey, look, you're healthy or whatever. We should plan to do this again in 3 years, or we should plan to do this again in another year because you're higher risk or you have some underlying chronic, health condition. So patients, when they call our office requesting a physical, we still book it in, but we kind of have this conversation that I'm having with you right now to educate them a little bit and change the shift away from it just being a top to bottom physical exam, without any of that history piece.
You've been working hospitalist medicine, you've been doing OR assisting, you've been doing a lot of admissions and emerge. You can elaborate, you can see it in both sides where, in hospital work, like often we focus on the issue at hand. We might do like an initial full head to toe on you just to make sure there's nothing we've missed. But once that's complete, it's really not necessary to spend like a full history, and a physical can take over an hour.
My office, I have a busy family practice. I work about 4 days a week in my office, and I get 10 or 15 minutes to do all of that. And then I come work a hospitalist shift, and I'm sort of allocated a lot more than that. I often don't take that length of time because there's just too many people to see, but I am given a lot more opportunity to spend a bit more time with patients. And so we're trying to do that in a very condensed form in the office, and that's not because we don't want to take that time. It's because we have too many people that need to be seen. And if we spent an hour with every patient, which I would love to do that, you would never see me. I would book 6 months in advance. So in order to have same day appointments, to get an appointment with me this week, I have to keep it to 10 or 15 minutes. I have to keep it to 1 or 2 issues. And that's so that everybody can access me in a fair way.
So shifting gears, because I think this is really special. So you were born and raised in Vernon. And now you're back here and you're raising your family here. And I just want you to share sort of what your love for Vernon is and your passion and why stay here. I think training rural, staying rural, coming to your home, it's a big deal.
Yeah, it's a really big deal, and one that we didn't think maybe would be possible for us. I know you had Dr. Devlin on, and he's similar to me in that we're both considered international medical graduates. So I went to Ireland for medical school. And so coming back to Canada is not a guarantee. And even being able to choose where you work when you finish your residency is also not a guarantee. Kind of was a perfect storm, and I ended up getting to Kelowna and then getting what's called my return of service here in Vernon, which is ultimately where I kind of had envisioned myself always practicing. And I love being back here. It's such an amazing community. I've lived now in Ireland, Victoria, Vancouver, and there's just nowhere like Vernon. Like most people here, enjoy the outdoors. I run and hike and ski. And so those were big draws. The size has been a big draw too. It's not too big, but not too small. And then our families. So my husband grew up here. His family is all here. My parents are here. My brother is not, but my parents are here. So we have lots of help when it comes to kids. Is really nice. But also it's just wonderful for our son to grow up with his cousins and grow up with his grandparents. So that makes it really special.
Oh, that's a great answer. Was there anything else you wanted to share with the audience today?
No, I think this is a great series. So thank you for kind of organizing it. And I hope that the community can get a little bit of insight to their local doctors that they may or may not see on a regular basis.
Yeah. Thank you so much for your time and for being here.
No problem.
We'll see you guys in the next episode. Thanks so much. Bye.